everyone, my name is Rachel Moses and you are listening to the HP Leader podcast. Now this podcast is a maybe 1 hour dietitian special, and we're going to be talking specifically about the role of the dietitian and the nutritional impacts of long COVID. Now, this podcast is to support a full study day we're running on the 17th of April. So you may have watched this podcast in preparation for that study day or after the study day. So hopefully we'll contextualize everything, and this will give you a bit more meat on the bones, if you like, to what we're going to discuss on that study day. So without further ado, I just want to let the panel introduce themselves. Ras, I'll come down to you first, please.
Hi, I'm Ras. I'm one of the cardio-respiratory dietitians at the Royal Brompton Hospital, and I'm currently doing a little bit of work for the BDA England board with NHS England and Improvement for long COVID.
Thank you, Ras. And Aaron?
I'm currently working as a dietitian in Bradford, and throughout this year I've sort of hopped around respiratory and ICU, and I currently am the dietitian within a long COVID clinic where we see patients there.
Thank you. And Elaine?
Hi, I'm Elaine Anderson. I'm an NHS and freelance dietitian with a background in stroke and neuro rehab and palliative care. I've also got a passion for workplace health, and I am also a sufferer of long COVID.
Thank you. And I'm very grateful, Elaine, for you joining this podcast with your two sets of views on this, as a person who's experiencing long COVID and also as someone obviously who is a specialist in the field. So thank you so much. So I want to start, and Aaron, maybe I'll come to you first. I've said this time and time again from someone that's worked in the critical care environment, we massively underestimated the nutritional impact of COVID-19 on our patients, particularly those that were so unwell they needed hospitalisation or critical care admission. So we knew very quickly that these patients were complex. Now, do you want to maybe just go through and remind us what some of those nutritional complexities have been in the acute phase?
Okay, so where would you like me to start? Would you like to start ICU, respiratory ward, work my way backwards? So I'll start from the respiratory ward and we'll work our way up. So it probably depends where you work, how patients are managed and things, but in my hospital, patients were managed on the respiratory ward until they were too unwell to manage anymore. Then they were transferred to ICU, and then obviously ICU took over. And I mean, a lot of the concerns with managing patients with COVID on a respiratory ward is one of the main tools that's used to support these patients is CPAP. So that sort of continuous positive airway pressure. So it's basically just blowing air in the face the whole time. And as you can imagine, air blowing in your face constantly and trying to eat at the same time is quite difficult. Sometimes these patients are given breaks on the mask so they can take the mask off, maybe switch to a less, so the CPAP mask quite tight on the face. They might switch to a mask where they can lift it off for a few seconds, pop a few mouthfuls in, that kind of thing. But it's still quite challenging. And also with these patients, they would deteriorate quite fast. So sometimes it's important to be prompt. And one of the biggest challenges we actually faced was the limitations of our nutritional screening tools. So one of the nutritional screening tools that's used widely around the UK is the MUST screening tool. A screening tool, as all screening tools are, they're to help pick up patients that wouldn't normally be picked up. And that includes many different aspects. So one of the criteria is BMI, and also poor nutritional intake, and then mine's gone blank. So it includes poor nutritional intake, BMI, and any weight loss the person's experienced, and their disease effect score. So it takes all of those into account. But often these patients wouldn't be referred to a dietitian until their oxygen requirements were so high they were unable to actually get a food in or place any sort of more aggressive forms of nutrition like a nasogastric feeding tube. So that was one of the biggest limitations. So we developed, in the hospital where I work, developed strategies to help be a bit faster, basically, act a bit faster, not based on screening tools. And then, so that's one of the main challenges on the respiratory ward. And as you go up to ICU, obviously you've got CPAP masks in ICU, CPAP hoods. I think my personal experience is CPAP hoods work slightly better for getting food in because they've got a little hole in, but that's just my experience. And then when the patients are intubated and sedated, that's a whole other area where there's feed intolerances and issues with various different things where patients wouldn't absorb feed because they developed an ileus or and then I know there's multiple different dietitians who are around sort of the critical care groups that are trained to place nasovaginal feeding tubes or small bowel feeding tubes. They had difficulty placing them on these patients. So I mean, there's lots of challenges actually delivering that nutrition to patients, and the challenges vary usually depending on the severity of the patient, and they change throughout the course of the illness or severity of the illness, and it really quite depends. And I mean, I didn't mention the fact that even patients who are not hospitalized, so patients at home or even say quite fit and well staff members, would have a period of time where they just really didn't feel like eating. The taste was off. It was just really difficult to the fatigue, the lethargy, the fact that I think one person described it, said, try eating chicken that doesn't taste of anything. It's just like eating almost like flesh of something or other. It just didn't have any feel to it, when you also felt a bit rotten. So I mean, various different challenges at different stages of illness.
So yeah, I'm just going to pick up on a couple of those points, because I think the first thing was about actually delivering the feed, whether that be someone who was physically able to eat because of they had the ventilation interfaces, or even just high flow oxygen, because it's quite difficult to coordinate swallow with some of the high flow devices, and of course if you're on positive pressure mask ventilation. And then in the intensive care environment, there was difficulties with tube feeding and with things like high aspirates. There was challenges in meeting the nutritional needs as well, in terms of the high protein requirements. These patients in this catabolic state, in this acute cytokine storm, so the additional pathophysiology on top of the challenges. Ras, I don't know if you've got anything to add from your acute kind of phase. And then Elaine, I was just going to bring you in for the more of the community, a bit what Aaron's just touched on there with the taste, appetite, and all of the other sides. So Ras, over to you.
Yeah, so I think just building on from what Aaron was saying, really. So exactly like you said, imagine when you have a cold and your appetite goes off for a bit, but then after a few days it comes back. This seems to be really elongated and sustained, and I'm seeing patients with COVID who are coming back months later and they've still got this really poor appetite. And we know that it is driven by hormones and different systems going on within our body, and that's quite a typical thing, exactly like you said, in the catabolic state, and it's cytokine mediated. But yeah, lots of other symptoms as well, things like taste changes, but they're not necessarily specific per person. Everyone is very individual, and so it's quite difficult to have like blanket advice for it. Things like when they're on oxygen, a dry mouth, and that can just be really hard to get fluid down, so you're risking things like dehydration, and thinking about things like IV fluids. Some of these patients we have seen have been having dysphagia as well, and swallowing issues, and I think also probably post-critical care as well. So we've been dealing a little bit with that. Exactly kind of like Aaron was saying, and you were saying as well, when these patients are so breathless, they can barely talk to you, how can they eat with that? I think psychological state is another huge one. So I think when these patients are feeling so unwell, and also so down about what's going on, that can really impact how they're eating as well, and their desire to eat, their enjoyment of food. And if you don't enjoy your food, you're not going to eat it. And I think probably nicely moving on to Elaine, but I think the other thing on that as well is families being really worried about patients and patients feeling a lot of guilt when they're not eating. We know these patients have higher energy and protein requirements generally. We know that these patients tend to lose their muscle really fast. They get sarcopenic, so they lose their skeletal muscle mass. And actually, anecdotally, in a few cases, I've also been seeing patients coming back and their muscle mass has just not been regained as well. So they're really weak, and that will impact nutrition in terms of being able to feed themselves and being able to cook and things like that. So Elaine, I'll hand over to you for that bit quite nicely, probably.
Yeah, that does kind of move on to kind of what I'm seeing in the community and what kind of type of patients that are kind of showing up and not showing up, which is what I'm also concerned about, because as we know, a lot of these patients are actually in the younger age category as well, and maybe not having access to maybe the long COVID clinics, and because their symptoms maybe aren't so much respiratory but more on the fatigue side of things, or maybe completely off the wall and in just like one symptom. But it definitely, the fatigue side of things can have a huge impact in the community, because particularly if someone's living on their own, trying to just, do their shopping, all that practical stuff can be really impacted on. Going back to taste changes, I mean, it's something I experienced myself. And when I was experiencing it, I was just thinking about all my previous patients I would have worked with, with COPD, with taste changes, or in palliative care, stroke and neuro, all of them, and how difficult it is to actually manage it, and all the things that you need to consider as a dietitian, and have the tools nearly up on the tip of your tongue to try and help people. It is quite hard to understand it unless you've actually experienced it, like anything, in healthcare. And other things just like breathlessness, like you've mentioned in the hospital, but also at home, just, eating a meal and just trying to get enough nutrition in as well. And actually, a lot of people I'm seeing, or I have seen through the long COVID Facebook groups, are also reporting weight gain because of the lack of activity. And that is going to be another side of things that as a dietitian we'll have to be aware of, is that kind of people's health might take a turn in another way because of their lack of activity and the types of food they're choosing because of their taste changes. As well, smell. I mean, people have been reporting, and I know I did have phantom smells where I would just smell for a full day, like burnt toast. So it would really put me off my eating. And I've heard people reporting this, 10, 11 months on. So again, another thing we need to be considering as well.
Wow, we'll definitely come back to the overweight, because I think that's something that we're probably not touched on anywhere else for sure. And food choices, I think, because I'd like to explore that a little bit more, especially if what can often happen is a patient's referred to a therapist, normally a physio or an occupational therapist, and then they'll do a system assessment more than a subjective assessment, and they'll ask all those questions. But actually, I think even knowing the basics, what to say sometimes, is really challenging, because long COVID is so different, isn't it? Mm-hmm. It is so different to anything else other than fatigue, those therapists that work in fatigue management, or complex breathlessness. So we've kind of covered what we knew from the acute phase, and we're now over a year down the line. I mean, every time I say this, it just freaks me out a little bit, but we've got 12 months plus experience of managing acute COVID patients, and now 8, 9, 10 months of managing patients, 6 months post-acute, a year post-acute. So what are we seeing in these longer term COVID patients? So think about the patients that maybe aren't or haven't been hospitalized, and Elaine, you've just touched on this a little bit, but without having a critical illness and severe illness, what are we seeing as some of the most longer term implications of COVID infection in the less severe patients? I mean, and I probably shouldn't say the less severe patients, but maybe the ones that didn't require acute hospitalization. Elaine, I'll start with you and then come down to Aaron.
I think they're being worn down because maybe of the lack of support that they're getting, and I think that can have huge implications on nutrition as well. So mood, like, you know, we've already touched on, you know, people are desperate now as well, and they'll try anything. And I think we need to be aware that on these long COVID support groups, and they're absolutely fantastic for getting information and sharing stories, but there's also a lot of information there that, you know, perhaps isn't evidence-based. And I know as dietitians, you know, and healthcare professionals, we need to be looking at the evidence base, but we don't have much to go off with long COVID at the moment. But some people are trying different types of diets as well because they're desperate to try anything. And I think there is a bit of a concern as dietitians that we need to be aware that people are trying things like fasting, or, you know, different types of diet, even the low histamine diet, which I know has been talked about quite a lot, which, again, I'm not saying that's right or wrong, but we just need to be aware of it because people are trying anything at the moment as well. But yeah, I think that people are sharing their stories, and it is helping. Just little tips and hints, and people finding, you know, when it's best for them to eat and things like that. So.
And I mean, if I think with my respiratory head on, nutrition is so important. If I think about like even pulmonary rehab, and we include nutrition and dietetics in that for this exact reason, because a lot of it can be simplified, but actually the context is quite complex. So actually this is why it needs specialists to be involved to help explain that process. I completely get it. Aaron, can I come down to you for your comments on that?
I'd completely agree with the fact that patients feel quite individuals in the community feel with long COVID feel quite desperate. They feel a lack of support, which is, my opinion, it's from two things. It's lack of knowledge from healthcare professionals for obvious reasons, because it's a new thing, but also the lack of available services out there. There's only a few local authorities that I know that are running really sort of effective MDT, really good pathway driven things that provide support for patients, whereas other times patients can feel quite lost. And the few patients we've had through GP referrals in the clinic that I'm part of always say, even though I don't think we can answer every question they have, they definitely say to me, I'm so grateful that we've been able to actually come to this clinic. And they do feel like a sense of they've got a few answers to a few questions, and it's been really, really helpful. I definitely would agree that people are trying everything. They're trying everything and hoping something sticks. They're buying they're probably not going to Holland and Barrett's, but they're going to like online stores and things like that to buy supplements they heard about, try this different thing, try this out, try this out, try this out. I've been asked about IV vitamins. So I think one patient was asking me, should I spend £250 on an IV vitamin drip? Will that help me? This one says it invigorates me and gives me energy. Will that help me? People say it will help. People said they felt energized afterwards. People who are experiencing loss of weight and malnutrition as a direct cause of the symptoms they're experiencing, and are trying approaches such as intermittent fasting or ultra-restrictive diets, which can be quite detrimental. And I think, especially with things that on some of these COVID support groups, I know there's a lot of discussion around the low histamine diet, and I definitely think that's a diet that I think dietitians need to support with to ensure that people get the adequate nutrition if that's something that they feel like they want to try. Because anecdotally on these groups, and I do watch them and I am on them just to make sure I'm keeping up to date with what patients are actually saying, they report it helps them. So I think it's important that we help support these patients, but in a safe and appropriate way.
Thank you, Aaron. Raz, have you got any additional comments on that before we move on to clinics?
Can you just remind me of the question? Was it just about what we're seeing, like coming through the doors like months later. Okay. So obviously I'm not probably seeing as many patients as Aaron and Elaine. I obviously still have a clinic and we've got inpatients coming in. I think still months down the line, we're seeing this effect of this poor appetite, which is still ongoing. I don't really know potentially like why that is. Patients are reporting to me that they're still eating a lot less of a portion size to what they're eating before. Kind of like I mentioned before, still kind of the muscle wasting and the weakness, and bringing in the fatigue element to that, that's really challenging for a whole number of reasons, because people are unable to go out and get their shopping, and they might not necessarily qualify for council support regarding help for shopping from like volunteers or local council, or they might not be able to get online shopping slots. Even things they used to do, like they used to have enjoyment of cooking, they're unable to cook anymore. And I think that can be such a big deal for people, especially people who provide and cook for other people, because it's a really challenging thing. They just don't have the energy to do that. Again, kind of, I guess that links a little bit more into mood as well. I think when you're so fatigued and tired constantly every single day and you're unable to do the things you used to do, I think that plays a huge role in kind of your mood. And we know that there are huge elements and a bidirectional link between kind of mood and nutrition as well. So that's generally just little bits and pieces of what I'm seeing coming through my doors, and still also some breathlessness. Oh, and also still some taste changes and loss of smell months down the line, still just not being resolved. Sometimes when we've seen them, for example, in cancer, it tends to get resolved within kind of weeks, months, but this just isn't seeming to get resolved. So then people are exactly what they're saying, restricting their diet because of that.
Thank you. I've got a couple of notes that I want to come back on. But before that, I just want to ask, what are dietitians doing in long COVID clinics at the moment? So if I think, then this is a really important question, in the fact that I am very aware that our workforce of specialist allied health professionals is really small. So even if we created all these posts tomorrow, we just wouldn't have enough people to fill them. So I'm always mindful when I'm asked this question, who needs to be in a long COVID clinic? I think really hard, because it means you're stealing resource from elsewhere. And, so we know that dietitians are a fundamental part of ICU follow-up clinics, like absolute no-brainer. We know that dietitians work in respiratory clinics and respiratory pathways. Again, absolute no-brainer. But we've seen a really important role for the dietitian in the long COVID clinics as well. And I have to say, I think from the very start, seeing the complexities in the acute end, we thought there has to be something in the community end as well, where these patients are going to get significantly nutritionally compromised. I hadn't thought of the other end in terms of the overweight and food choices, actually, till you've just mentioned it there, Elaine. But Aaron, coming down to you first, a patient comes into a long COVID clinic and they need a dietitian, what kind of things are you doing with that patient?
So I think, I started off pretty similar to you, and not 100% aware of what we would see, basically, because obviously it was started up, I think, I can't remember the dates, July time. Started up. So I thought, I stepped back and I talked with the physios and also the consultant that we do the clinic with, and they were doing various assessments like the 6-minute walk test. So I decided I would do hand grip and use the SARC-F to sort of would get a decent functional assessment from those two things. And also I decided to use a malnutrition screening tool just to ensure that whatever sort of things they're experiencing. So I use the PGSGA, so in order to capture any data that I was actually seeing in clinic. So I use those two things as well as other parts of the assessment. And again, as things have been mentioned, like the fatigue, things like that, the barriers that people face to nutrition, helping them overcome them through strategies we may have learned in various different areas, and then the lack of exercise, the difficulty with using difficulty with the way people are feeling. They're feeling frustrated, they're feeling tired, they're feeling fed up, because I think the way I'm probably not the best person to speak on this, but from my impression, that people feel like they've literally 2 weeks ill and their life's completely changed, and it's taken away not only through restrictions that have happened, but also their ability to go out and do things that they could do before, and they took for granted but don't take for granted anymore. And it can be quite fit, healthy people as well, and which can be even more startling to them. And I think there's an element of real frustration and despair that the answers can't, there's no easy answers to anything. We can't give them all the answers they want. So I think that can be quite frustrating. And some people do, and they've used food to help manage various different emotions. And then some people at the other end of the spectrum, and they restrict food to help manage various different emotions. So it's really quite complex. And I've actually had to rely on some other members of specialities to have advice and support with some of these patients, because they come from various different experiences, challenges that are facing. So I do try my best to help do a comprehensive assessment, and then we try and figure out the best plan going forward for the patient, whether it be to see myself again or to see a specialist in various different areas. I haven't mentioned all the specialists because it really does vary. It's gastro, diabetes, weight management, various different areas, and it's just working with them with patients. So I think it's a little bit of that, sort of working with others, but also helping those sort of more ones that have a bit more of a different mix of symptoms that are making eating and nutrition a challenge for them.
Thank you. Elaine, coming into you, please.
Yeah, I mean, it sounds like, Aaron, you've seen a whole spectrum of the long COVID patients from a nutrition point of view, and you've really captured kind of the variety of what is happening in people's bodies. And I'd like to touch on what you mentioned about the frustration, and, you know, something I know I've experienced, the kind of, I was fit and healthy before this, and like most people thought, oh, it'll just be a 2-week flu. And then that really does have a big impact on your mental health when, you know, 3 months down the line, you're not getting better. And it definitely impacts on, you know, people's lives and food and everything really, which ultimately, you know, all tends to stem back to how they're feeling. So I've nothing really more to add to that really, other than that I think you've definitely, you kind of covered that no one person is different, and as dietitians we need to look at the person holistically, like in any rehab setting, you know, and to listen to them. I think that is a big thing that has come out of a lot of conversations that I know I've had with people, is what one thing would you advise healthcare professionals to do, and it's to just listen to them and listen to what they need and they want support with, really.
Thank you. And I definitely want to finish on tips and hints and go back to some of the things that I've got written down here. But Raz, I want to come into you. Now, you mentioned at the beginning about the task force and you being involved in some conversations, maybe at more centrally or higher levels. Like, what's going on behind the scenes? And anyone can come in and answer this as well. But have you got any pearls of wisdom for us?
Not at the moment, unfortunately. It's still very much early days. I think there are a lot of discussions going on across everywhere, including on like local levels, just about the best way going forward to treat long COVID, and also about funding. But I think that's going on at every single level, so I don't unfortunately think that's any secret.
Yes, the F word, the funding. Elaine, you mentioned there was maybe some things going on as well in the pre-chat.
Yeah, there's been a bit of work going on with the University of Plymouth and the BDA. I know I've sat on a panel initially as kind of somebody living with long COVID, but I was able to contribute to the work that's going on, and hopefully maybe we'll see some sort of work come out of that. They haven't decided on what it's going to be or what it's going to be called, but certainly just gathering expertise from different areas. I know there was people who, you know, were from all kind of representatives on that panel, so it was really good to see everybody coming together. And I know I've been involved in some work with the food allergy specialist group of the British Dietetic Association for particularly around the low histamine diet, because I think it was something that as dietitians we needed to gather together and kind of get a position statement, or, you know, just some agreement around what we're doing with that. And really the main message for dietitians is that, you know, yes, the evidence isn't there yet, but we still need to support people if that's what they're asking for, because otherwise they will just go somewhere else and get the information and it might not be as well supported. So that's kind of what I've been involved in recently.
Yeah, and I mean, for me, what we've got to learn from this as allied health professionals, or what we've got to try and monopolise on or take advantage of, or however you want to frame it for me, is that these patients will have ongoing nutritional needs and requirements that exceed or that are different from what was normal when they're in this post-acute phase. So that's critical illness, that's complex respiratory disease, like long-term conditions, when, especially when it involves the cardiovascular system and breathing, because it's like running a marathon every day. It's the same with neuromuscular disease, neurology conditions, chronic fatigue. So for me, that would be the big thing that we need to say to everyone, like, look at what happened to these patients in the acute phase, in what we're seeing in the community. It needs a specialist interaction. And I think the thing for me is that when people are involved in the MDT clinics and they can pick things up or spot things that other people just won't ask the questions about, it can be that then 1 or 2 or 3 consultations, whatever it might be. I think commissioners often think you have to see someone for like 12 weeks, and it's like, no, it can be like 1 or 2 contacts. You have an individual care plan that people go away with, and in your case, a nutritional plan. So that moves me on to like hints and tips. So Aaron, I think you mentioned intermittent fasting, and just that struck a chord with me because I was tagged in some kind of tweets or some conversation that was going on about weight management for these patients. Elaine, like you said, my naivety thought the weight gain would be around just pure inability to exercise or to be as active as like what someone would be for maybe a younger person. And people eat the same calories. So I know this because when I used to be an athlete, when I stopped playing like more professional sport, I used to eat the same, and very quickly I realized that I couldn't do that. But is it as simple as that, Aaron? Is it just people are more sedentary after they've had, you know, a viral illness and they're still eating the same, or is there other complexities?
First, I just want to clarify. When I mentioned intermittent fasting, it's not something that I would recommend, or even I'd probably advised against it with the majority of with the vast majority. I can't think of one where it might be a very applicable choice. But again, it's about working with the patient and seeing what goals they have and helping them to get the best sort of nutritional outcomes there. Just to clarify, I wouldn't say intermittent fasting has, in fact, it's probably quite low down the list to be any sort of help with treating any of these conditions. However, along with the exercise and the inability, I think from my own experience, it's a combination of factors. Most often for a lot of people, it's probably the inability to exercise and the lost amount of energy expenditure there, but also the lack of social activity, or the lack of being able to go out, the lack of being able to do the activities that they did before that occupied them. So often they can be at home, and obviously the home is where food often is, and people can maybe eat more than they would normally eat because they're usually occupying their minds with various different things. And again, the the mental health aspect as well, that does play into it quite a lot as well, because as we've mentioned, the vast changes. And I just want to clarify this. I think I was seeing a conversation on Twitter about, someone mentioned clinical psychologists needing to be in long COVID clinics or supporting long COVID patients. And by no way has anybody that I've ever met believe that it's to turn a phrase, all in their head. It's not at all. There's many a patient that's come in and we've noticed actual sort of physical signs, but even if not, these patients are experiencing real symptoms and real things going on. But it's more to cope with the psychological impact of those symptoms on those patients. Hopefully I've sort of answered the question, but I've also added things in.
That's
Sorry about that.
interesting, because I was having conversations with psychologists, and often I think it's around behaviours, and you modify your behaviour. So this is why with the eating question, I'm really interested, because I'm thinking about that conversation I've had with some psychologists as well. It's you, when you have like a longer term illness, or let's say long COVID, you start to modify your behaviours, which then come normal. And we see this with the breathing pattern disorder as a kind of compensatory reaction, or coupled with anxiety. And I know people don't maybe like that word, but I think people do get anxious when they get fatigued and they get short of breath, and it's then they develop this pattern of breathing that compensates for the breathlessness, but it's because someone's fatigued and because they do need to breathe deeper. Or so with eating habits, and Elaine, I'll come in to you for this. Is it, I can't think of any other words to use than poor food choices?
Yeah, I mean, it can be, because maybe those are the easiest foods to make, for example, you know, maybe getting takeaways because they have no energy to cook, you know, or even just eating things that, like going back to the smell and taste changes, that if that is a really prolonged, you know, issue for them, then yes, they will probably choose the more unhealthy things, maybe the sweeter things. Again, personally for me, the first 2 weeks of my, you know, initial infection, I could only really have something that was sweet and crunchy and had a kind of a nutty flavor, so cereal. And luckily, you know, I knew that I couldn't eat that forever, but, you know, not everyone maybe knows how important nutrition is and how important it is to get a balance even in the early days. And it might be just lack of knowledge that maybe their diets before they had COVID weren't maybe optimal anyway. And so they continue on that trajectory of whatever they were doing before, but it's different now because they are more poorly. And we're seeing things like iron deficiency anemia, and particularly amongst women, and, you know, just different deficiencies in vitamin D, because a lot of these patients who will have been inside for, you know, since, especially if they got COVID in the early days, they haven't really been able to get out and exercise. They might be vitamin D deficient. And I think as healthcare professionals, we're so aware of vitamin D and how we, you know, but not everybody is aware. And I've even seen posts that people are taking a supplement and they're getting checked and they're still deficient. So there's, you know, a lot we don't know what's going on there either with malabsorption, perhaps. You know, there's a lot of research that needs to be done. And I know that, you know, COVID, the virus has been found in the bowel, you know, 3 months after infection. So who knows what that's doing. So there's so much we need to be aware of, really.
Thank you. Now, Ras, coming down to you for hints and tips for good nutritional advice. And I know we joke about this, don't you? Because dietitians love their food, and you love your food, don't you, Ras?
Yes. So, I think that one of the main things, though, is actually reassurance, and to be providing permission to not do things like you used to. I think nutrition has huge connotations within society and within our culture and the way we live. And I think it can be really challenging when you're used to having nutrition a certain way your whole life, and then everything has to be turned upside down and you can no longer have things the way you used to. And I think that's why it's so tricky to give blanket advice and blanket hints and tips, because it's so different per individual. I think that's so important. And I think exactly what Elaine was saying with the listening, I think that's why it's so important, because you won't have two of the same people coming through the doors. But I think giving permission to them that things are not going to be the same and it's okay not to be doing things like it was before is actually a huge thing. I think one of the other things which is quite important is we know that COVID has disproportionately affected ethnic minority backgrounds. And so I think it's really important that as dietitians, we are upskilling in cultural foods from around the world, because we don't know who's going to be coming through our doors. And I speak to lots of dietitians who often tell me about the fact that their education in this area isn't particularly up to a high standard. And I know there are some amazing dietitians who are doing lots of work on this, but I think that's one of the other kind of hints, tips and tricks I would give to dietitians, is to start upskilling on that as much as possible. You won't know everything and that's okay, but I think it's beginning to research that area a little bit more.
I mean, that's a great point, Raz, and obviously we are approaching in Ramadan now. In terms of how will that maybe affect some people living with long COVID? Do you think we're going to be asked, therapists that are listening, nurses that are listening, do you think they'll get asked more of those questions about fasting?
I think potentially, and I think we know that people with health conditions also don't necessarily have to participate in Ramadan. However, I think what there might be concerns are regarding it is when we think of people being really fatigued, nutrition is really important just for patients to have enough energy. And sometimes we often recommend in these patient groups, when they are really fatigued, the kind of little and often pattern, which probably everyone talks to their patients about. And obviously during Ramadan, that's not going to be easy to do. You won't be able to do that at all, because there will be obviously only a set time you'll be able to eat, a set number of hours. So I think it will be about liaising with your doctors and just trying to make the most informed choices where possible, and also monitoring where you're feeling and how you're feeling during the day, and monitoring your energy levels in regards to your appetite and hunger and things like that as well.
Thank you. Aaron, coming to you next. Any comments, hints and tips for people who might be seeing these patients that don't have access to a wonderful dietitian like yourself?
I think again, as I'll be the annoying person, and as everyone else has been annoying, I'll be annoying too. It really depends. It depends on what the people are experiencing, what they're going through, what their major nutritional challenges are. I do also think that as dietitians, I think sometimes patients can, as Raz has said, almost feel like they had these habits before that were really effective and really productive and did X, Y, and Z really, really well. And because this drastic change has happened in their life, those habits are really, really difficult to get back together. Like even habits that people may think that, oh, why can't I do that? None of my symptoms restrict me from doing that. But due to the other things going on and the massive changes in their life, and it's about helping people develop habits that will help them recover, whatever those habits may be, around their new life situation based on symptoms they're experiencing. So it might be helping someone to eat a little bit more to help them regain some of their strength, or maybe they've lost a dramatic amount of weight, or maybe they're trying to prevent further weight loss. So again, working around some of those symptoms and trying to develop those new habits within the confines of their new experience of life. Because I think everyone's probably experienced it when sort of the restrictions happened and people couldn't do things. But I think definitely patients who have experienced long COVID have experienced it a lot worse I want to make sure that's a lot worse. And that, I think it's nice I think what Raz said about being almost be kind to yourself, to coin a phrase, just give yourself a little bit of, speak to yourself how a friend would speak to yourself, rather than sometimes that unhealthy self-talk that people can have. Because I think definitely, as I've talked to many of these patients and they explain what they're going through, that some of their expectations for themselves can be quite debilitating. Like, I can't say their expectations are wrong, but they can be really hard to achieve for them. So it's, again, trying to help them to reframe and think about it in a different way, to help them to, so it's about really supporting them, but not pushing them in a way just because you think that's the right way or they should expect to do that. But it's about trying to help them understand that something has changed and they might need to take a little bit longer, and that's actually okay. And it's normal, to coin a phrase. A lot of people who are experiencing long COVID don't feel like anyone else. They feel quite lonely quite often, because they don't seem to, they'll go to medical professionals and no one seems to know any answers, and they seem to struggle. They find a community online, but outside, family members, friends don't quite understand what they're going through. So actually saying, this is, other people who are experiencing this, can actually be quite, from a medical professional, can actually be quite reassuring, and offering suggestions based on what other people have experienced, and then allowing them to help fit it into this new experience that they're having, is probably where it would work. But again, everything depends on the situation, doesn't it?
Absolutely. And I'm going to come to Elaine for one more question, and then I want you to have a think about anything we've missed out or some final comments. But Elaine, if it's the physiotherapist in me, right, I would say things like stay hydrated. If people are feeling, sometimes it's just the energy that's required, like you said, to make a dish. I would say, okay, maybe eat little and often, have a bit of variety. I mean, Raz, you've definitely got me thinking, because that would normally be for me like meat and 2 veg, have a piece of fruit. It's just when I think about my upbringing. But one thing I never take for granted is sometimes some of the basic information that sometimes people just don't know, because maybe they've been brought up on what I would class as poorer food choices, like very processed foods, salt foods. That is definitely, frozen foods. That's just convenience foods. That is cheaper. It's cheaper as well. That's a fact. If people are out of work, or they're maybe lower income families. So, and the other thing that long COVID patients have been feeding back is this binge eating. So when they do have a bit more energy, they suddenly have this overwhelming like hunger, and they'll find they'll just like eat a lot of food. And I mean, we've never had more food available to be delivered than any before, particularly in London. I mean, the world's your oyster, isn't it? So what kind of, just some final thoughts on, I know I've said a lot there, but is that kind of the right advice? Stay hydrated, maybe eat little and often, a bit of variety in fresh vegetables and fruit.
Yeah, it is hard, because as Aaron said, it does depend on the situation. But if as a physiotherapist and you want to kind of, or even just kind of asking the question, have you been eating well for you? Have things changed for you? Have you lost weight? Little kind of, just not so much probing, but just kind of, how are things going on that front? And then it will guide you towards what would be the best things, because it's all well and good saying have something, have a balanced diet and try and get a variety. But if they turn around and say they've lost 2 stone, then that obviously you'll be looking at a slightly different advice potentially, and referral on hopefully to the dietitians. So it is really hard to just kind of give that kind of blanket advice, but even just asking the questions will help guide you towards what might be best for that patient within the nutrition side of things. And it might make them realize as well, maybe it hasn't been top of their list, that I haven't really been eating my breakfast in the morning because I'm too fatigued, but then I'm really fatigued for the rest of the day. And then it's kind of putting two together. Actually, maybe I need to be eating more regularly and putting fuel in putting petrol in the car, like I would have said in my fatigue workshops, because you're not going to go very far if there's nothing there. So it's just like little things like that as other healthcare professionals can kind of pick up on, and maybe then, if need be, refer on when needed. But the little and often is obviously a brilliant one for the weight loss. And if someone has lost a lot of weight, the usual things dietitians will say, full fat dairy products, drinking milk, all of that kind of stuff.
Thank you. And the point that I want to make as we're wrapping up is actually calculating individual nutritional and calorie needs is quite complex. I think people kind of think it's quite easy, but it is quite complex and takes in lots of factors, doesn't it? Especially the stage of recovery you're in. So yes, for sure. But I'm just so aware of so many patients out there that just don't have access to any form of nutritional or dietetic support. Aaron, like you said, hence the online community call outs. So I'm going to come round everyone, and Ras, I'm going to start with you for any final comments or thoughts.
I think most people have said everything, but I guess the most important thing going forward is just to be a little bit more patient, potentially thinking about where your service does allow. I know it's not always possible, but sometimes double appointments might be good and might be necessary in some of these patients. They might need follow-up a little bit sooner if your service allows that. I think the patient's part is one of the most important things working with this cohort. So yeah, that's my final thought.
Thank you, Aaron.
So I think one of the main things for me is, can you hear me? Yeah, one of the main things for me is just, again, making sure that we're, again, I think they ask for other healthcare professionals asking those questions. I think if you want a model, I think the patient association have got some good things on their website about asking some just basic questions that you can ask over the telephone that can sort of trigger further conversation around patients who might be losing weight and might require further nutrition support. But I think it's about what I've really learned is, I think going forward, I think there's lots of dietitians doing fantastic work in the area. You've got three of us here, and I know all of us are doing work in the background because I know various different email threads that I'm a member of. Everyone's working in their own area, working really, really hard. And I think we don't know everything just yet. So again, it's about making sure that our assessments are done well, and we think about as much as we can when we assess these patients, and then support them the best way possible, and do that accepting that we don't know everything as well. I think that's quite an important part, and sort of sitting in that sort of area. And I know that every other healthcare professionals sort of is sitting around there and working with previous experience and applying that to this new situation. But I think just making sure we follow best practices, but also remember that we don't know everything as far as long COVID goes.
Thank you, Aaron. And Elaine, final thoughts, please.
Yeah, so I agree with everything that's been said, and I think coming from a place of being a person living with long COVID, just for healthcare professionals and dietitians to realize kind of the impact that long COVID can have on somebody's life, even if the person actually is sitting there looks healthy enough. Actually there's a lot potentially going on beneath the surface, whether that's psychological or physiological. And just to continue, as we all would do normally, to treat that person holistically. And like Aaron said, kind of, we can't solve all the problems. So perhaps we might need to refer on to a specialist gastro dietitian or, whatever. But it is important that we are aware that there might be things that, the patient needs to follow up on in different areas as well. So yeah, it's just listening as a dietitian, and yeah, hopefully helping in some shape or form.
Well, I just want to say a massive thank you to you for joining me this evening. It's been a real pleasure, and again, just stressing the importance of the dietitian as part of MDT. not just for long COVID, but particularly in this recovery phase of COVID and the global pandemic. So thank you so much, and thanks for all the behind the scenes work I know you're all doing. So thank you very much.